Hi, everyone. Thank you for joining today. This is our sixth and last session in this current series, Enhancing Your Client's Health Check. Thank you for joining. I hope you had a wonderful 4th of July holiday, and thank you for your flexibility in moving this last session so that more people can attend. Today we're going to have a Q&A with the Geriatrics Professional Panel. So we hope you came with your questions and are ready to be engaged. This session is going to be recorded, and the link to the recording will be sent in our next week's email. This is our agenda. It's kind of following the same structure it's followed the last 6 sessions. So this is we're going to start with our welcome and introductions and announcements, followed by our Q&A session, which is going to be taking place of our didactic session for today. And then we will still have a case discussion that was submitted, and then we'll move into our closing and reminders. You have been muted upon entry, so if you do have a question for the panel or want to speak up, please feel free to unmute yourself at any time. If you want to speak, please go ahead and introduce yourself with your name and location so we know where you're from. And then if you are speaking about a specific client, please be sure that you maintain confidentiality when speaking about your clients and refrain from including any identifying information. The session is approved by the Board of Registered Nursing for continuing education credit. And as we've done in the past, if you do want the credits, go ahead and fill out the link that will be sent to you after this email. This session is supported by the Health and Resources and Services Administration, and any information here or content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. We'll go ahead and move on into our introductions. Please take a second, if you haven't already done so, to introduce yourself in the chat. We love to see where you're all joining from. Please include your name, role, site, and location, and we'll have our hub team introduce themselves. And these hub team members are also our panelists for today. So my name is Nika Seville, and I'm the project manager for our Geriatric Workforce Enhancement Program, and I'm at UCI Health in Orange County, California. And we'll go ahead and have our panel and hub team introduce themselves today. Dr. Sagel.
Good afternoon, everyone. I'm Sonia Sagel. I'm a clinical professor with the Division of Geriatrics at UCI, and it's my pleasure to be here today.
Thank you. And Dr. Gibbs. Dr. Gibbs. I think her audio is having some problems. I'll have you introduce yourself in a second. PA George.
Hi, I'm Valerie George. I'm a physician assistant. I work here at the Senior Health Center Geriatrics, and great to be here with you all and discussing our geriatric patients. Thank you for inviting me.
Wonderful to have you. And Geraldine Date.
Hi, I'm Geraldine. I'm the social worker in the Senior Health Center, and nice to be here.
Wonderful to have you. And Jorge?
Yes, hi. Good afternoon, everybody. My name is Jorge Soleil. I'm the Assistant Director of the Elder Abuse Forensic Center.
Thank you. Wonderful to have you. And Carlos?
Hi, everyone. Happy Friday. My name is Carlos Garcia, and I'm the Data Analyst for our Geriatric Workforce Enhancement Program. Welcome.
Thank you. Dr. Gibbs, is your audio working?
Can you hear me now?
Yeah.
Yes.
Oh my, sorry about that. Yes, so Professor and Chief of the Geriatrics Program at UC Irvine, and it's wonderful to see everyone again. Thank you.
Wonderful to have our hub team with us. Looks like everybody in the chat has responded. We have Deborah from Meals on Wheels in Alameda. We have Kimberly from Meals on Wheels San Francisco. Quite a few from San Francisco. We have some from Long Beach, Meals on Wheels Orange County, Meals on Wheels California, San Diego. Thank you all for joining us today. I hope you came with your questions. We are going to go ahead and just move straight into it. We have a few questions that were sent in earlier, but we wanted to go ahead and start off with those of you on the line. If you have come with your questions for the panel, you can ask specific panelists a question or address the whole group. You can also take this time to ask questions to people on the line. You can follow up questions from previous sessions we have had, like on dementia, on stroke or elder abuse, falls risk, changes in condition, or any other subjects that you have questions about that you think our panel can address. So if you do have any questions, you can feel free to type them in the chat or go ahead and unmute yourself at any time to ask our panel questions. Anybody on the line like to go first?
I'm happy to go first. It's Daryl. I hear often from EDs and social workers and RNs that if a person needs to be moved from independent care at home into an assisted living situation or something that has more support, that is really difficult to convince someone of. And yesterday I happened to have an 87-year-old in my home. She looks like she's about 65, but she definitely has dementia. And she's recently moved into assisted living at the insistence of her family, and she's very unhappy about it. And I just think that negotiation that you have to have with parents or loved ones or clients is really tricky. I'd love to know if there are any sort of inside tips on that.
Thank you, Daryl. That's a great question. Okay,
Valerie?
Hub team.
Yeah, Valerie, would you like to take that one?
Sure. Thanks for the question, Daryl. You know, that happens with our patients quite a bit. Always to have that decision making. Also the loss of independence, right? So someone who may have maybe a mild dementia, I'm not sure if your person has a mild or a moderate dementia, they may not have the insight to see exactly where the need is or that they need extra help versus what the family is seeing. Or a lot of times there's also family dynamics, right? So can the family provide the care that that person needs, or if there's repeated hospitalizations or, you know, things are not being followed through on, like medication management, or maybe they're losing weight or things like that. Sometimes it can be presented over a period of time. I know with our patients here, it might be kind of just broaching the subject. And then once it's kind of introduced, it's really sometimes the family is the one who has to kind of make the move. A lot of times it can happen during the hospitalization or the ER because that's a transition time when they're not at home to move them. It takes anywhere for 2 to 4 weeks to maybe even get into a time on that they are maybe in an acceptance, or they may not ever get into acceptance. But you have to give it time. So if the person goes to the ER and then you see them right away right after that, most likely they're going to be like, no, I hate it here, I don't like this. But it's also trying to encourage the purpose behind it to be more social, have meals planned, make sure medications, and reiterate the safety part of it is kind of the bigger deal. And then having the family also to try to, you know, bridge the gap if they need to see other family members, or really try to introduce socialization so they feel more comfortable there. I'm not sure if that helped. I don't know if anybody else has anything else to add on to that.
Thank you.
Yeah, I would agree with a lot of what everything that you said, but also that if there's an opportunity to prepare for that discussion and have an open discussion before it actually needs to happen, that helps a lot, because it's not coming as a complete surprise that everyone's been afraid to talk about.
Good point.
I agree with both Dr. Gibbs and Bell, but I also think looking at the facility, so looking at the location and making sure that the offerings of the assisted living or the resident care matches the patient's personality if possible. So if it's a very social person who enjoys, you know, having an evening hour of mingling or games or outings, if possible, you know, to match the patient's personality with the offerings of the institution, I think is really important.
Thank you. Daryl, did that answer your question?
Yes, it does. Thank you.
Thank you. And Geraldine, it looks like you put something in the chat.
Suggest not visiting very often during the adjustment phase, because the person that just moved into the community sees everyone. It's great to have them visit, but they also see them leaving and leaving her behind, and that can be really confusing. So I would not make a lot of visits in the early stages. I would give her some adjustment time, and then make routine, meaningful visits.
Thank you. Does anybody on the line have another question? Or if you'd like to type it in the chat. Mary O'Connor, do you have a question?
Excuse me, I should have probably typed this, but a few sessions ago, for the first time, I heard the term agers used. I had never heard that before. We're talking about our agers, and I just wondered if that's sort of a new vernacular, you know, in working with older adults. I think it might have been Geraldine that said that. I can't remember for sure, but I hadn't heard that term before, and I asked a few of my colleagues and they had not either. So I wondered what that's about. Thank you. Thank you.
Sure. Thank you for your question. Would anybody like to address that?
Yeah, I've done some research on intersectionality, and when we are addressing the age span, especially with multi-generations, the term agers seems to be a healthy and friendly way to talk to families intergenerationally about somebody who is aging. So it sends a sense of inclusivity, because 100% of us are aging, and so that's what I've been understanding would be kind of a current way to discuss it with multiple generations, to explain somebody who's aging and their needs.
Thank you. Thank you very much.
Thank you for your question, Mary. Anybody else on the line who'd like to ask a question? Okay, we have a question that was submitted that we can move on to. And first question is, how do we speak to family members who are showing signs of dementia, and what are the signs? How do we convince them to be safe? Who from our panel would like to take that question?
So
Go ahead.
Oh, I can start. I think, Val, please jump in. So in terms of the signs and symptoms of memory impairment, or, things that you notice that might have you concerned. So if someone is repeating themselves, or repeating certain conversations that you've had as if they're new, or asking you asking you the same question over and over, forgetting that you visited or phoned them, confusing family members, or forgetting family members, having issues calculating or balancing their checkbook, missed bills. Those would be some signs that someone is having issues with short-term memory. Sometimes people can have personality changes as well. So someone might have been very mild-mannered their entire life, and then all of a sudden are becoming a little more aggressive or irritable, or disinhibited. So they might be using profanity when they didn't use profanity before. And so those would be things I would look out for, and that might have me concerned. Depending on your relationship with the person, it can be very difficult to bring up these concerns in conversation, particularly if they're being brought up by a child, because there is a parent-child dynamic that is established over decades, and so some folks are not necessarily willing to hear that what your concern may be interpreted as criticism, which it definitely isn't. It's concern. You're coming out of a place of concern. But I think gently bringing it up, and again, as with the prior question, a lot of these things have to be discussed over time, gently, slowly, and in a very respectful way. But it's difficult, especially if you're, especially if it is a parent or a grandparent, and you've been in a dependent relationship for a long time. Valerie, I know you had some comments too.
Well, I think that we see this quite a bit in our clinic. I've had patients, I've been here, gosh, over almost 19 years now. So to see them change over time, we can see it. So sometimes we can recognize it maybe a little bit better than the family member. And sometimes when the family member is close, they don't always see it. But then you get a family member who calls from out of state, or someone who doesn't see it all the time, and then they can see a decline. But I agree with Dr. Sagal. Repeating often, even now, I just had a patient earlier today, the medications are not making sense. He's not following, picking up his medications correctly, or his blood sugar is really high where he used to be very excellent. And I've talked to him many times, I think you're a problem with your memory. No. And he's without any family members. So, and the idea is also to be safe, is to just recognize that sometimes even like if they have a history of fall or some worries about those kinds of things, I introduce things that may be helpful, like a pill box, or using a walker or a cane, because that, I always put that quote in there, this will allow you to be more independent on your own, with some backup things to make you still be able to do your things, but it's a safety measure in return. And then you can see if they get medications in a pill box, you can see if they're taking them or not correctly, and then we can follow closely. And then that's another way to bring up, hey, I see that things aren't going as well. So that's all I had to add. Thank you.
And then the other thing too is that this can be tricky depending on the provider's office, the primary care doctor that they see, or provider that they see. But sometimes families members will give us a little heads up. They'll either send us a message, or they'll talk to us before the meeting, before the appointment, and they'll say, I'm kind of worried about mom's memory. And I'm sure I'm speaking for my colleagues here, we're happy to be the bad guy and bring it up. And we have all kinds of ways in which we can subtly bring up assessing one's memory. And the most common is, well, you're 80 years old now. We screen you for colon cancer. Let's screen your memory. Let's screen you for memory issues, because they do become more common. And we're happy to take that burden on, having the discussion and making the recommendations for any lifestyle changes that might need to take place.
I wonder, this is Jorge Soler. I'm wondering if part of the strategy here in speaking to family members is also making them aware of some of the safety devices that can be put in place to help prevent some accidents. I know that at the Forensic Center, we've had several cases where clients tend to leave the stove on, and there is in the market safety devices that actually turn off the stove after a few minutes of being left unattended, as well as there's other things in the market. So I think that part of the conversation with family members is making them aware of those resources or those devices that can help a little bit in situations like this.
Absolutely. And, I think it's important to preserve your relationship with the person that you're concerned about. Because if it's a parent, you want to preserve your relationship. And if you can outsource some of the caregiving, if possible, put some of the burden on the provider, I think it's important to preserve your relationship.
Thank you, guys. We have a question in the chat from Caitlin Goodman that says, do you tell someone with dementia or Alzheimer's that they have dementia or Alzheimer's, or do you suggest we word it different? For example, if someone lives in a memory care unit and they ask why they are there, how would you address that?
Well, I think it really depends on their level of comprehension. I mean, if you're really speaking with somebody in memory care already, it's probably good to just try to discern how much they can really comprehend. If they're just, with mild memory problems or dementia, then I usually try to mirror the words that the family is using or that they're using. If they're using the word dementia, I use the word dementia. And if they're just, if the patient seems to be accepting the fact that they have memory problems, then I might go with that phrase. But I also don't want to treat dementia as if it's a bad word. Certainly it's a very legitimate medical condition. And so, if I don't think it's going to really affect someone's acceptance of the fact that they're getting particular treatment because they have dementia, then I will go ahead and use the word dementia. But then if you have somebody who's moderately to severely, demented, they may not have a comprehension to really even understand one word over another. So we end up just saying maybe, well, when people get older, they need more help, and this is a great place to get it. So it really does depend sometimes on the situation and mirroring the vocabulary that the patient and family uses, without, again, making dementia a bad word.
I agree. And, if someone has some significant short-term memory and you introduce, if you tell them, well, you have this diagnosis of dementia, I'm not sure what that really means to that person, especially since I just look at it as a label. It's really a label for the symptoms that someone's experiencing from this illness. And, we see sometimes where patients forget that they've lost their spouse or that their spouse has passed away. They have dementia because they have short-term memory impairment from dementia, and their kids will say, well, dad died, and then they'll grieve, and then they'll forget, and then 2 weeks later the kids will come by and say, oh, dad died, and then there's a whole grieving process that happens on a repetitive basis. And so I think if the patient's going to grieve every time that we tell them that they have this diagnosis of dementia or this label, I definitely wouldn't bring it up, because I don't know that it's necessarily therapeutic for us to keep reiterating the label.
Thank you so much. Great question. And let's see, the next question from Joe Garza is, what is the reason why someone who has dementia or Alzheimer's would become very aggressive? Is there a reason for that?
I can start off with an answer to that. My interpretation of their agitation or aggression is that there's some confusing aspect of one's environment. So, when you have cognitive impairment, you may not be able to perceive subtleties in the environment around you. And so changes in that environment can be scary, frightening. They might make you sad, and you don't have a way to express the emotion in an effective manner. So we might express our fear by saying, I'm scared, but someone who has dementia may not be able to do that. They don't have the words to relay that, or they can't say I'm scared or I'm lonely or I'm sad. And their manifestation of that emotion sometimes can be through agitation or aggression. And so rather than to try and medicate these behaviors, we really try to advocate for environmental change. So changes in the environment or accommodations in the person's environment so that they feel more comfortable, rather than using an antipsychotic or other mood stabilizing medication. I don't know, Dr. Gibbs or Val, if you have any other thoughts about that.
No,
Now-
I think,
Oh.
go ahead, Dal.
Oh, I was just going to say, also with a sudden change of aggressiveness, could be you need to have them maybe follow up with a primary care physician. Could be a change of like a urinary tract infection. They can't express things as well. They're not going to say, "Oh, I have pain with urination," like a younger person may. And it might be just that change of behavior that is showing up. So usually I'll try to run labs first, maybe complete blood count, also a comprehensive metabolic panel. But a lot of times, majority of times, it could be just a urinary tract infection. And once medication is on board, their mood or behavior comes back. And then also trying to work on redirection. If this is what Dr. Sagal is saying, if they had a change or the environment is different, to try to take away that fear. Sometimes people get fearful of not some strange things like people fearful of seeing their reflection in the window, or perhaps that they somebody does not look similar, or other things can happen. They have hallucinations where people come in. Those things all have to kind of be addressed, and then try to redirect so it's not so fearful for them. Okay, Dr. Gibbs.
Yeah, no, I was just saying, yeah, we did have someone who fearful when he looked in the mirror because he was unable to recognize that that was himself. He thought that someone else was looking at him. As the connections in the brain really break down, they say one person with dementia is one person with dementia. Everybody has a different process. Everybody has different memories that may be deteriorating, or different experiences as those connections unfortunately break down. And so that's why, depending on the person's personality and history and experience, you have so many different reactions through that whole continuum of the disease. Also there may be patients who have experienced trauma in the past, and they may not, now have those boundaries that they put up to deal with that trauma may not be working for them anymore. And so they might all of a sudden start to be afraid of certain things or certain people, and sometimes we will never know that history. So we'll never really understand why people are, becoming agitated or really aggressive, or maybe starting to become violent. Whereas if we were in their shoes, we might do the same thing. We just have to understand they're coming from a place that makes some kind of sense in some way to them, but that they're not truly violent, they're not truly aggressive. But and in that situation, we just have to make sure the caregivers are safe, but that we don't, think badly of people when they're becoming aggressive or violent or agitated.
Thank you so much, Joe. I hope that answered your question.
Yes. But
Wonderful.
just one more thing. I've noticed from experience that when a family member would try to get them into the shower or to a bath, sometimes they get very aggressive because they don't want to go into the shower. I don't know if they're fear of that, or they forgot they normally used to take a shower, but now they're not sure what they understood when they go.
Thank you.
I think that that's always a great question, because I don't really know what that is. But from what I observed over time is that I think it's almost like a fear of a small space. And if you really think about taking a shower, there's, especially with a tub, there's a lot of maneuver of going in and out. So there's a risk of fall, and they may be afraid of that. And also, this water's coming down, and they may not understand the process of what's happening, like we normally notice. But I think from what I've just understood from my patients and families, I think it's more kind of a fear of a small space. So sometimes we'll just have them, cut it down to like twice a week, maybe sunbathing, or sponge baths, if family or caregivers can help with that. There is some fear there. I don't have a true answer for that.
That's a great answer. And also I just wonder sometimes how, one's vision plays into that, because we know that visual spatial perception also is affected with dementias, many of the different types of dementias. So it may be a complete feeling like, they're just not in control and they are going to fall, or they can't tell where the wall is, or how the water's coming down, because that whole visual spatial, sort of skill that you need is no longer there.
Thank you so much. We have a few questions in the chat. Daryl asks, do you think now with the newly approved medication for Alzheimer's disease that people will be less fearful of hearing that they have dementia?
Well, that's a great question. I think if they perceive that the medicine is going to work, they might be. I think we're more skeptical about the results and the outcomes of those studies. So if they actually speak with, someone in the medical field, they might get a reality check. I mean, these are by no means cures. Changes may happen on a patient by patient level, but there's no indication that this is going to be a miracle drug. So, it just kind of depends on how the media is going to spin this and what they read in the news. And some people may just on the surface say, hey, wow, there's a great drug out now. There's a new drug, okay, now we can go get tested. But, I think as people understand more and more about this, there may be some disappointments. Not to say that it may not do any good. I just think that there needs to be more studies, and a lot of people feel like it was approved a little bit prematurely. Dr. Sagel, happy to have you add to that if you have any other comments. It's a hot topic.
I agree with you. I think there's some controversy around the FDA approval of the medication, and whether the studies warranted approval at this point. So I don't know that it's going to necessarily change patient perception of this illness. I think that was one of the reasons, if I'm not mistaken, why the nomenclature for cognitive impairments was changed to move away from dementia and call it major neurocognitive disorder of a certain type, so that people wouldn't feel that stigma, this word dementia. But for people who are anxious about developing a dementia or a neurocognitive illness, or have a strong family history, I think it's important to understand where they're coming from and really advocate for a healthy lifestyle. So healthy diet, exercise, blood pressure, and blood glucose control. And that's really important to, do everything you can in your control to prevent cognitive impairment down the line.
Thank you so much. Another question, do you have any insights on the role that meditation might play in intervening against dementia?
So I don't think we have enough research to tell us that yet, but we do have research that shows us that people who meditate actually experiences change in brain structure, and it can differ based on the type of meditation. So what we can say is that meditation does change the brain structure and actually reinforces certain areas of the brain depending on the meditation. What we don't have are studies that show us if that in the long run helps prevent dementia.
Thank you so much. Let's see, we have another question that was submitted. I think we already probably answered this question, so let's move to the next one. What if a family member or someone refuses help or says they will not go to the ER or the hospital if they need to? How would you address that?
I can take that. This happened this morning in my clinic with one of Dr. Gibbs' patients, and really back and forth with decision making, back and forth, and ultimately decided not to go to the emergency room. And you know, it's difficult. It's all about trying to explain the need, the purpose, why it's different to go to the emergency room rather than waiting. Sometimes it's just the amount of wait time that they have to go. And on our patient level, we try not to send people to the ER because we know that it's going to be anywhere from 3 to maybe, you know, 4 or 5 hours, 6-hour wait, and that is not good for our patients. But if people are generally sick, it might be, it just has to be deemed necessary. So again, it's all presenting the problem and why it can't be settled within the clinic. So at home, you know, it's different. So you guys are going out in the home and you see something. Again, it's all about safety. If the patient or person does not look well, it's kind of a responsibility to make sure that they're checked out. So you could turn it over to, you know, emergency, call 911 and have the paramedics try to talk to them about that. Have family members come in and then have them, I hate to say that, but maybe they say, okay, well, we're going to take a ride, and then they just kind of arrive over at the hospital. Just different ways to how to assess it, especially if they have memory loss.
I think it's important to understand what the reluctance is. So during the COVID surge, you know, people were reluctant to go to the emergency room because they thought they were going to acquire COVID, and that was very frightening. And you know, all kinds of things were missed and care was delayed. Sometimes people are afraid of the wait time, and if they are afraid of the wait time, I usually tell them I'm going to call the ER and let's find out what the wait time is. And if it's too long, let's find a different emergency room for you to go to. If it's fear of, you know, the family members not being able to accompany them, or that maybe they're afraid of the illness that they have, you know, really trying to address whatever the fear is and trying to acknowledge that, and letting the person know that you're going to take steps to, whatever is in your power to help them through that fear or perceived barrier. And sometimes, oh, sorry.
No, I was just going to add that another reason that I come across is folks not feeling that they can afford the service. They have no medical coverage, or they cannot pay out of pocket or something like that.
Absolutely. Absolutely. We do see that in our clinic sometimes too. And letting people know that, that those financial issues, you know, when you go to the emergency room, they can be worked out later, and no one's going to be turned away.
Anyone on the line have any additional questions before we move on to the next question? Okay. Yeah, Mary just said thank you. That cost concern is a big issue for people, especially like with the ambulance cost. Okay, how much do we trust our seniors to tell the truth when they are ill?
So maybe I'll start off with an answer. I trust my patients if they're telling me about a symptom that they're having or a concern. I trust them. I trust that they're being truthful about it. I think sometimes patients tend to be stoic, or they may be hesitant to share information about, you know, chest pain or something, because they're really worried about the outcome, and there's some anxiety around the outcome, or what they think might be happening to them. And I think a therapeutic relationship, letting them have the opportunity to speak and validating whatever concerns that they have or their fears, is really important. And sometimes, because of that hesitancy and that anxiety around a particular concern, information doesn't come out as readily. So they, you would think that, okay, they could give you this whole history in like 5 minutes or 10 minutes or 15 minutes. Sometimes the history comes out over 3 visits, but it's usually because there's some anxiety around what's happening with them, and just meeting them where they are. So I tend to trust my patients. I don't know if that was really the intention of the question, though.
I think too, though, sometimes they downplay. They will downplay because they don't want to bring up that something's really wrong. But as Dr. Sagel said, if you start to have more interaction with them, ask them more questions, sometimes things leak out a little bit more, and then you can kind of play onto that and kind of get down to the bottom line of what's happening.
Thank you so much. Anyone on the line have a question? Okay, we have one more question that was submitted. How much pressure do we put on older parents or family members to do what we think is right? So it sounds like if there's differing opinions, and there's some follow-up questions that come with that. For example, what are the dynamics within the rest of the family that come into play? For instance, if my father-in-law is acting erratic, but his son doesn't want to discuss, or a grandfather or mother says they don't know what is wrong, they just don't want to drive anywhere, but say their eyesight is fine, what is the next step? So how do you deal with differing opinions between you as a provider versus what the family might want?
I was just thinking that maybe Geraldine has some insight to this. I see she's putting something in the chat, but maybe she could talk about this a little bit.
Okay, hi. Sorry, I'm having some computer audio issues, so sorry about the delay. I was just commenting on something you had said earlier about building that trust and understanding and starting where they're at. But I think in terms of this question, there is what we think is right and what they think is right, and we really have to separate our need and want versus what the goals are. And so you had also mentioned earlier, Valerie, that just reminding the patient and ourselves that the goal is always, if the goal is always safety, that we could agree on something. So starting where we could find some space where we are congruent and we're a team and we can agree on something. And if that something could be safety, I think that is always a healthy place to start, and then bridging other conversations from there. I hope that helps.
Thank you. Anyone else?
The driving question too, I often caveat that as retirement from driving. So putting that out there.
Okay, does anybody have any other questions they'd like to ask the panel before we move on into our case discussion?
You know, I just want to say this is really about communication, and sometimes our families come to us with issues like this. So they actually, as health professionals, we actually start these conversations with families, and that's really what it takes. It just depends on the family dynamics. If you have potentially one child that's used to really, that's comfortable with these topics, they may be the one that need to start this conversation. But I think this is a little bit different in all families. And sometimes when the conversation starts, the older adult is relieved, to hear it, that it's brought up, relieved to find out that there's other alternatives to transportation, even though they may not be as ideal. But truly, this really boils down to communication. And we have a geriatric assessment clinic, and oftentimes I feel like when families are at a crossroads, that's when they actually look for options like our clinic, because we're used to speaking this language, we're used to bringing it up. We hold family conferences And so that's one way to do it if the family really doesn't communicate, is to take this to a health professional that understands these sorts of issues.
Thank you. Okay, if you all have any questions that come up while we're working on the case discussion, don't hesitate to type them in the chat, and I'll be sure to get to them. But we'll go ahead and move on into the case discussion. Looks like our case presenter is Christy Hirsch, who's a social worker at Meals on Wheels San Francisco. Thank you again to our panel, by the way. And but yes, Christy, are you on the line?
I am, yes.
Wonderful. So while Christy is giving an overview of your case, please think about follow-up questions you might have for her, or think about how you handle the case, or resources you have at your site to assist this client, or pull from your experience working with your Meals on Wheels clients, so we can go ahead and discuss after she provides an overview of the case. Let me go ahead and share the case that was submitted. And Christy, if you can give us a quick summary of this case, that would be wonderful.
Absolutely, and thank you so much for inviting us to share a case from our San Francisco program. We really appreciate the opportunity. So what I'm talking about today is one of our clients we've had for a few years now. She's 70 years old now, living alone in the apartment where she's been in for 45 years. She shared that apartment with her mother and took care of her mother until she passed away. She's completely homebound, so never leaves the apartment, which is on the second floor, due to leg pain. And she has a great fear of the elevator because she had a fall in the elevator. And so she won't use the elevator. One of the things that is challenging in this case is she has no official medical or psych diagnosis on record because she has no relationship with any medical professional because she's a Christian Scientist and so doesn't believe in medical intervention. At this point, she uses a seated walker and can ambulate short distances in her apartment. She is unable to transfer in and out of cars and things like that, which is an addition, to the obstacle to her getting anywhere. She has difficulty maintaining her hygiene in her home. She has a high level of anxiety, and it's really difficult to get her to stay on topic. And she really perseverates on certain things, but there's no glaring memory issues. So her cognition seems to be intact in some sense. She has a contentious relationship with the landlord, building management, and most of her neighbors. She's estranged from her sister. There's one neighbor that helps her out minimally. And that is it. She couldn't provide us with an emergency contact. She doesn't want people in her home. And thus it's been really difficult getting her any kind of support. She is low income and SSI recipient. Her rent exceeds her monthly income. And she has managed financially through the generosity of members of her congregation, which she has a lot less contact with now because of the pandemic. And that one neighbor that helps her to sell personal items in order to make rent. She has, in my work with her, agreed to do certain things. She's active with CalFresh, so she has food stamps now, which the neighbor will help her with. She has rental assistance through a couple of different agencies in San Francisco. She has Meals on Wheels, obviously, and a monthly food box that is delivered from the food bank. And she was also willing to engage with a remote senior center. She participates in teleconferencing senior groups by phone. But she's had multiple open APS cases due to self-neglect. We've tried to hook her up with case managers with other agencies, long-term case managers. That's been unsuccessful. And we've been unsuccessful in connecting her with formal in-home help, transportation support, home-based primary medical care. She was referred twice and accepted into that program and then didn't follow through. Programs to install grab bars or other safety things in her apartment. Volunteer matches, technology programs to get her connected, and she has a corded phone. She won't even switch to a cordless landline phone, so despite efforts. So it's been really difficult, and she represents kind of a larger issue that we have with some of our clients where they're requesting help, but really apprehensive to engage with any formal services for a variety of reasons. And so a lot of our clients are in this pattern where we're just doing watchful monitoring, and we're told by Adult Protective Services to allow them to fail, you know, to a certain point, then where intervention is not their choice anymore, but mandated. So just wanted to see in this situation here, if there is anything, any ideas anybody had about how to engage this client with formal services, which she's saying she wants, but then self-sabotages. So it's been very challenging.
Hi, Christy. This is Jorge Soler. I have a question about this client. You mentioned that she is belongs to the Christian Scientist Church and that there's some church members that are helping her out. Have you reached out to the church itself for some help? I understand that the Christian Science Church has Ministry of Christian Science nurses that actually go out. Is that something that has been explored?
You know, with her, no, I haven't. And that's a very good suggestion. She was very heavily involved with the congregation years back. And since the fall in the elevator that caused her to be homebound, and then the pandemic, she's lost touch with a lot of people that were providing one-on-one support to her. But that's a very good idea. It's something that I can do, contact like the larger organization, because she has not been willing to provide any personal contacts that she's had at church, names or phone numbers for us to coordinate with. But that's a very good thing to explore, because I did not realize they had that.
You are in the San Francisco area, right?
That's correct, yeah.
So I think that in the San Francisco area, it's the Ardenwood, just the community of Christian Scientists. They are in the San Francisco, in the city of San Francisco per se, I believe. So that may be a resource for you on that.
Perfect. That's really great suggestion. Thank you so much.
Mm-hmm.
Do any of our registrants from other Meals on Wheels member agencies have any feedback or any questions for Christy about the case?
One follow-up question, Christy, if you don't mind. Has a formal capacity assessment been done on this particular client? Do we know her cognitive functioning level?
We were trying to, and UCSF up here has a really great home-based primary medical program through which you can access those types of things. And she, despite her religious beliefs, had requested home-based primary care because she was in so much pain. And so twice the referral went through and she was accepted into the program, but then she refused to do the initial appointment with the provider in her home. So we haven't been able to make that connection go through. She's been really non-compliant with those types of referrals once they get to a certain point.
And I've seen your narrative that APS has been involved or is involved. Mm-hmm. Do you know if they, I know that San Francisco also has a forensic center, an elder abuse forensic center. Mm-hmm. Have they considered bringing this case to the forensic center over there to kind of brainstorm the case?
They haven't as yet. But it would be a great case for the forensic team to consider there. And it's a really good, you get a lot of good feedback from those meetings too, which I attend regularly. No, they haven't. They've been very hands-off with her. They helped at one point. We have in-home support services here, which she fully qualifies for, to get some formal in-home help. And she also at one point said she wanted that, and it was difficult because you had to circumvent the medical certification that was needed in order to qualify for that program. But APS was able to work with in-home support services to do that. But when it came time for her, when she was certified and granted hours, she wouldn't allow anybody in her home.
I see.
So it was, yeah, so they brought it to a certain point and then kind of backed away, or really holding in high regard the client's self-determination, her religious beliefs and things like that, and waiting for her situation to just decline further.
Right. And that's where the question of capacity comes into play, because obviously if she's found not to have a capacity to take care of her basic needs, that would warrant a referral to the public guardian's office for possible conservatorship or something like that. So at least that's the course that we would take here in Orange County if a case like this was to be presented at the forensic center of the case.
Yeah, well, and that is certainly what motivates this client more than anything else, is the financial stress that she's constantly under.
Right, right.
Yeah.
She's on SSI, so
She is. Mm-hmm.
there may be some facilities that would, where she, her SSI benefits would cover some of her care and stuff.
Right, yep.
All right.
Yeah.
Thank you.
No, thank you very much.
Anyone else on the line? Anyone from Meals on Wheels have any suggestions, or maybe had a similar case?
Well, one more question. Sorry.
No, please, this is great.
I keep thinking, going back and thinking, did you say that she's not eligible for in-home supportive services?
She is eligible, and she
is.
was certified. The obstacle we ran into was they need a medical certification from a doctor to certify her disabilities and medical conditions and the need for this kind of help. And because she has no relationship with any medical professional, there was nobody that could do that. But Adult Protective Services was able to circumvent that in order to get her certified for it. But then she just wouldn't allow anybody in her home. So she kind of cut that. But she is, yeah, but it was offered to her, and she is, being an SSI recipient, completely eligible for it. It's a pretty easy process, since there's not too much that needs to be confirmed with regards to income and, those qualifications.
I see.
Yeah.
All right. Thank you again.
No, thank you.
Mary says, thank you, Christy. Would you say a little bit more about the harm reduction lens in cases like this?
Sure, Marie. Yeah, because in San Francisco, for sure, we take our practice approach is definitely harm reduction. We really, like someone mentioned earlier in this conversation, really try to start where the client's at and focus on, what they are, adjustments that they're willing to make and the problems that they recognize that they want to address. And so the fact that, small successes are big to us in our practice with the clients. So the fact that, after 5 visits, she allowed me further into the apartment than the front hallway, or, she allowed us to do certain things with CalFresh, with the rental assistance program, that required her to provide a lot of documentation that she's not necessarily comfortable with. And, so there are things that we were able to do to try and begin to address some of the issues that she was dealing with. I mean, even just in the sense of being a sounding board for someone who's so very isolated. And so there are things that we have been able to do, things that are in place now that wouldn't have been in place if not for her involvement with Meals on Wheels. And that's really what we try to look towards in San Francisco with our approach to clients. Or, sometimes it's real baby steps, to get a person headed in the direction that might be a good direction for them. And planting seeds, always planting seeds on what's available, even if they're not ready to engage at that time.
Okay, any last minute comments? I know we're kind of out of time. Christy, were we able to kind of, I know, it seems like you're doing a lot of, what everybody was already suggesting, but I think there were some suggestions that came out of that. Do you kind of
Yes,
have
thank
next
you,
steps in
Jorge,
mind?
very much.
Thank you so much, Christy. And I appreciate our panel and everyone who submitted questions today. We hope this was a successful series for you all and that you enjoyed all the sessions. We truly are so thankful to be able to, put this together with our partners at Meals on Wheels California. And thank you to Holly Hagler and Daryl Tordahl and you all for helping us put this together. And, we hope to continue to provide ongoing series in the future. And we would really appreciate your feedback. So please, I'll send this link out to you all after this session, but we really appreciate your feedback. This evaluation is a little bit different than the other ones, just so we can get end of series feedback. It'll just take 3 minutes. So please fill that out. And if you do want CE credits, make sure you fill out that CE form as well. Any last minute comments from anyone?
I'd just like to say on behalf of Meals on Wheels California, thank you so much to UCI and all the panels and the expert advice we've gotten. It's really been wonderful. And I hope people will submit questions that they didn't get answered and perhaps in their surveys. And so we can make sure everybody got what they needed, but really a big shout out to UCI. Thank you.
Thank you so much, Daryl. And if you did submit to get CE credits, those should be coming to you all via your email in the next few weeks. So look out for those. And if you have any questions along the way, you'll have my email once I send the PowerPoint presentation to you all. So feel free to reach out at any time. And again, thank you so much for speaking with us for the last 6 sessions, and have a wonderful weekend, everyone.
Thank you.
Thank you.
Bye.
Bye.